Thank you so much to the organizers for inviting me to share our work with you. My name is Sarah Sheppard and I'm a clinical geneticist from the Children's Hospital of Philadelphia. Today I'll be discussing our work looking at molecularly targeted therapy for patients with mosaic KRASopathies. For my disclosures, my mentor, Dr. Hakonarson, as well as our hospital have equity in a company that's developing MEK inhibition for treatment of complex lymphatic anomalies. First, I would like to introduce our comprehensive vascular anomaly program led by Dr. Adams and Dr. Hakonarson. This is a wonderful team of both clinicians and researchers that work together to provide care for these patients. Like most clinician researchers, my work starts with a story about a patient. This was a little boy whose mother was evaluated in our fetal center at 29 weeks gestational age. At that time, he had been diagnosed with a fetal arrhythmia, and an orbital mass had been seen on his prenatal ultrasound. This is visible in the right orbital area on this 3D ultrasound here. Unfortunately, even though the arrhythmia was controlled, he developed bilateral pleural effusions and ascites, which necessitated delivery at 33 weeks and 4 days gestational age. When he was born, his growth parameters were within normal limits. Now, during his prenatal course as well as his postnatal course, and given some of our evaluation, we found multiple additional congenital anomalies, including hemimegalencephaly, additional ocular abnormalities such as hypoplasia of the right optic nerve. He had some osseous thinning of the frontal bone, a lipoma in his spinal cord, a cystic kidney, and cryptorchidism or undescended testes. And throughout his body, he had multiple sebaceous nevi and Blaschkoid distribution. Once his arrhythmia was controlled, he still continued to have issues with effusions and ascites, and a lymphatic disorder was suspected. He had dynamic contrast magnetic resonance lymphangiography, which identified a central conducting lymphatic anomaly. This is a rare type of lymphatic malformation that is characterized by leakage or dilation of the central conducting lymphatic vasculature. Panel A shows the intrahepatic DCMRL. There's perfusion into the lungs as well as the mediastinal lymphatics, as well as some retrograde perfusion into the mesentery. Panel B shows the intranodal DCMRL with retrograde perfusion into the mesentery, the right cystic kidney, as well as the dermal lymphatics. There was an intraperitoneal leak noted, as well as an intact thoracic duct. Given his clinical presentation, we suspected a mosaic disorder and sent genetic testing from his nevus sebaceus. This identified a mosaic pathogenic variant in KRAS or RAS GTPase that signals through RAF, MEK, and ERK. Mosaic pathogenic variants in KRAS are known to cause epidermal nevus syndromes or mosaic RASopathies, which can include multisystemic congenital malformations like those seen in our patient. Previously described lymphatic complications in mosaic KRASopathies include lymphangiectasia, lymphangiomatosis, and lymphatic malformations. Mosaic pathogenic variants in KRAS have also been described in Gorham-Stout disease, a type of complex lymphatic anomaly which is characterized by destruction of the bony cortex. Previous case reports have discussed the use of trametinib or sirolimus with patients with mosaic KRASopathies, but little detail has been reported about the efficacy of these. Dr. Dellinger's group also recently described the efficacy of trametinib in a KRAS-driven model of Gorham-Stout disease. Now we have identified 2 additional patients with central conducting lymphatic anomalies due to mosaic pathogenic variants in KRAS. Panel C shows the intrahepatic DCMRL for one of these patients with retrograde flow into the lumbar and iliac lymphatics, the splenic lymphatics, as well as an intraperitoneal leak. She also has some bilateral pulmonary and mediastinal lymphatic perfusion, and no thoracic duct is visualized. Panel D and D' are the intrahepatic and intranodal DC-MRLs from an individual that presented with lymphedema and a chyloscrotal leak. There's a normal appearing thoracic duct with some retrograde lumbar perfusion and intraduodenal leak, as well as dilated iliac lymphatics and retrograde dermal perfusion into the scrotum and penis. So we hypothesized that these KRAS variants were causing the lymphatic dysplasia in these patients by increasing RAS-MAP kinase signaling, and based on our previous work, also hypothesized that MEK inhibition would be more efficacious than mTOR inhibition. The majority of these studies I will show you will be for the G12D variant, but we've also performed similar studies for the G13D variant. We first put the activating variants into human dermal lymphatic endothelial cells and stained with VE-cadherin to evaluate the endothelial cell junctions, or actin to evaluate the cellular cytoskeleton. Human dermal lymphatic endothelial cells that had been transduced with the wild-type KRAS had normal appearing cell junctions and cellular cytoskeleton. However, those with an activating variant really lost these normal appearing junctions and cytoskeletons, and these cells had these longer extensions as seen by the circles. Treatment with binimetinib or trametinib, both which are MEK inhibitors, rescued this phenotype and led to normal appearing cell junctions and the actin cytoskeleton. Next, we used phosphorylation of ERK as a metric for signaling through the RAS-MAP kinase pathway. Cells expressing the KRAS G12D variant had an increase in phosphorylation of ERK compared to the wild type. Both of these samples had a decrease in the phosphorylation when treated with trametinib or binimetinib, which is quantified in the graph. To evaluate migration and proliferation in a more biologically relevant system, we used a lymphatic organoid model. Human dermal lymphatic endothelial cells are placed in a well that's been coated with agarose gel. These aggregate together to form a little ball of cells, and the sphere is implanted into collagen, and we can watch the sprouts. This is an example of what we see under the microscope, and to look at the effect of the variants or the effect of drug treatment, we quantify both the number and the length of the sprouts. Both the G12D and the G13D variant led to a significant increase in the cumulative sprout length as well as the number of sprouts. However, only the G12D variant led to a significant increase in the mean sprout length. These phenotypes were all rescued by treatment with MEK inhibitors, binimetinib or trametinib. Next, we used the Zebrafish to evaluate the effect of these variants on the developing lymphatics in vivo. We expressed either the wild type or mutant KRAS under the control of an MRC1A promoter, which allows for expression in the lymphatic and venous endothelium. We evaluated the zebrafish at 7 days post-fertilization and found that the wild type KRAS fish appeared relatively normal, as did their lymphatic vasculature. However, larvae that had previously been injected with the PG12D had large edematous areas around the heart as well as the tail, and we also saw fusion of the thoracic duct with the cardinal vein. At higher power confocal microscopy, one can see the tumor-like proliferation of the vasculature, which is reminiscent to our patient's lymphangiogram. Next, we used the zebrafish model to identify good drug candidates. We treated the zebrafish larvae from 2 to 5 days and then screened these embryos for edema as a marker of how efficacious the drug was. The white boxes are the controls, and the gray boxes are the drug treatment. We tried several different MEK inhibitors with all slightly different mechanisms of action and found that all tended to reduce the fraction of larvae with edema, but only some of them were statistically significant. Conversely, when we looked at mTOR inhibition, which is generally thought to be standard of care, what we found was that sirolimus, or OSI 027, which is a mTOR inhibitor being developed for vascular anomalies, we found that none of these mTOR inhibitors led to a significant reduction in the fraction of larvae with edema. So, in summary, mosaic pathogenic variants in KRAS are a cause of central conducting lymphatic anomaly. I showed you that we're able to mimic what we see in the patients using these in vitro and in vivo models, and that MEK inhibition is efficacious in these model systems. Further work is really needed to understand the mechanism of lymphatic dysplasia using these model systems. And finally, further trials of MEK inhibition are needed to understand the safety and efficacy. My colleague, Dr. Kristen Snyder, will speak to you a little bit about some of the translation of the work that we've done from these patients presented here. Thank you so much to the patients and families for participating in our research, as well as my mentors, Dr. Hakonarson, Dr. Adams, and Dr. Dory. This work is not possible without our huge team of clinicians and researchers, especially Dr. Dong Lee, Dr. Michael March, and Dr. Mark Badig, and Dr. Christoph Seiler. I'd also like to thank all of our collaborators, as well as the funding, including a grant that I've received from Uplifting Athletes and the LGDA. Thank you so much for your attention, and I'll take any questions.